Hi, this is Dr. Chee-Wee here. Welcome to this video on the measurement of pain. In this video, I'll be talking about why and how we measure pain. Now before we start, here are some of the aims of this video. At the end of this video, you should be able to first, understand the purpose of measuring pain, and two, appreciate the multidimensional and subjective nature of pain and how this influences how we assess pain. And lastly, you should be able to state some outcome measures we can use for assessing different aspects of pain and its impact. Now, pain is one of the most common symptoms that patients seek help for and from physios. Now, the reason for this is that any form of acute injury will be accompanied by pain as the first warning sign. Although this is unfortunate for the patient, this can be used to our advantage as clinicians. Now, provided there are no complications of the injury, we can use pain as one of the indicators of improvement. This will help guide our baseline assessments and development of our treatment plans. This also means that we can use it as one of our outcome measures for determining the effectiveness of treatments. Pain can also be used in most cases as a facilitator for our diagnosis. General principle is that if an irritating structure causes pain, this is usually the offending structure. There are of course exceptions to this. Now this includes referred pain and chronic pain. Before we attempt to measure pain, it is important to appreciate that pain is multidimensional in nature. The reasons for this is that pain is constructed in our brains. Now, nociceptive information from peripheral tissues sends noxious information to our brains that then interprets this as pain. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Inherent within this definition are two important concepts. Firstly, that pain consists of different components. This includes the sensory, affective or emotional, and cognitive aspects. More broadly, social and contextual information can also influence the manner in which we interpret pain. Secondly, it is possible that pain can be experienced if there is no ongoing observable tissue damage. In the case of chronic pain, that is conditions that are longer than 12 weeks, it is likely that the original injury has already healed by then. However, patients still complain of pain. The facilitators of chronic pain can be many, which is why we need to look at all the dimensions of pain. This can be explicitly checked through the use of yellow flags in our subjective assessments. For those of you who are unfamiliar with yellow flags, they are a set of questions that indicate if a person has increased risk for having chronic pain will result in long-term disability and work loss. From the point of view of our clinical assessment, we need to provide a comprehensive and accurate record of our assessment of the person's complaint of pain. To capture these information, we can use a combination of outcome measures and recording tools to help us create a clinical narrative for our clinical assessments. One thing to note is that we should judiciously choose the appropriate pain outcome measures because we cannot assess them all within the limited time that we have with the patient. This is when a good subjective assessment will help guide us in this choice. A very important principle when measuring pain is that pain is always subjective. We can try to obtain physiological correlates of pain and observed behavior. Now, these in themselves are not pain. Our own personal experience and histories will influence the way in which we construct painful experiences. Therefore, we should always accept each patient's report of pain as pain itself. This is especially important if there are no observable link between tissue damage and the person's pain report. When we get down to the actual measurement of pain, there are several domains that pain outcome measures usually fall into. The first and most commonly used is the pain severity. This describes the person's report of the magnitude or intensity of pain. We can use simple tools like the visual and analog scale, or the VAS, or the numerical rating scale, the NRS, to do this. These scales are very commonly used in the clinic. The measurement of pain quantity isn't simply restricted to the sensory aspects. We can also use these scales to measure pain unpleasantness as well. The second outcome type that we can measure is pain interference. In our clinical encounters with patients, we'll often need to record succinctly the pain complaint in our notes. One very efficient way of doing this is to use the body chart to draw out the pain complaints. Imagine we have a middle-aged lady who has been experiencing general decline in her condition over the past 6 to 8 months. She has increasing difficulty in doing transfers at home and increased reliance on her wheelchair. She was also complaining of numbness in her knees, hands and trunk in recent months. This is a body chart of a complaint. If you just look at the screen and look at all the areas that's been shaded. Now there are several steps to drawing this body chart. Firstly, you'll notice that there are 3 pain regions shaded onto the body chart, specifically on the knees. A useful thing to do is to label them with an alphabet to note the distinct regions that they sit in. The next description is the quality of the pain. Is the pain constant or is the pain intermittent? What about its depth? Is it located superficially or much more deeply? Then you can write in the pain severity using either the VAS or NRS. In this case, we have used the VAS on a 0 to 10 scale. Now, one additional thing that can help in your assessment is finding out if the pain regions are linked and what activities connect them together. Or perhaps they are independent of each other. If they are linked, what is the sequencing of the pain occurrence? Do they appear all at the same time, or do they sequentially appear one after another, depending on the duration that the activity is engaged in? Other pain-related information that you will find out that is not here in this body chart are the aggravating and easing factors. That is, what activities make it worse and what makes the pain better. The 24-hour pattern of the pain. Is it the same throughout the day, or are there times when the pain is worse or better? Now, all of these information will help you in your assessment and diagnosis of the person's problem. Now let's come back to the outcome measures again. It is good and well to say that we should use outcome measures in our clinical practice. Nevertheless, there are some important considerations to think about when choosing which outcome measures to use due to the constraints in time and resources that clinicians have. Firstly, how long does it take to administer the outcome measure? Usually, short outcome measures take about 2 to 3 minutes to complete, and longer ones range between 5 to 10 minutes. If you are collecting a few outcome measures, this will obviously eat into your clinical assessment time. Is it possible to get a patient to fill in the outcome measures at home first before bringing it in when seeing you? The next consideration is whether the outcome measures are simple enough for the patients to do it on their own, or do they need help? After the patients have filled in the outcome measures, how long does it take for you to analyze the data? Is it simple enough to just tally the data, or does it need post-processing for it to be clinically relevant? Now, this would have an impact on how much time you'll be spending with the patient. Most of the outcome measures mentioned previously are simple enough to be used in the clinic and also tested in clinical population for ease of use and interpretation. These are some of the things you need to look out for in addition to the measurement properties like validity, reliability, and responsiveness issues relating to the specific outcome measures. So here are some of the things that we learned about pain outcome measures when using it in our clinical practice. Firstly, we need to consider what is the baseline data that is essential for us to make a clinical diagnosis, but also to be able to reassess for improvement and determine if our treatments are effective. Secondly, it may sometimes be necessary to assess the wider impact of pain, for example, emotional distress and interference to activities, and by choosing the appropriate outcome measures to determine the degree of impact of these other issues. Thirdly, remember to choose outcome measures that are robust psychometrically. That is, always think about the validity, reliability, and responsiveness of the measures. But also remember that constraints within a clinic may mean that the outcome measures you need, that you're chosen needs to be easy to use and to interpret. Okay, so this is the end of the video introducing you to pain outcome measures. So have a nice day, and I'll see you at the workshop.